My name is Katie Farrell, and I'm glad to be sharing this time with you today. So this is the suggested route of what we're going to be talking about. I am a practicing clinician, so I tend to do more back and forth than I do presenting for multiple hours. I also tend to adapt what I say and how I say it to the people who I'm speaking with. And that means that I would love for you to tell me if something doesn't make sense, if there's something that you want me to talk about. I'm happy to answer any questions that you bring up, or at least attempt to answer them. There'll be brief question and answer periods throughout. Feel free to type your questions. If I have any questions during these Q&A sections, Brittany or I will ask you to unmute in order to clarify what your questions are about. We have a little bit of a split presentation here. Some of you are here for continuing education units as counselors. Some of you are here more for your own interest, your own kind of education. And what that means is I've split the presentation into two different parts in essence, where we have the first section, which will likely be about an hour, and that will be about me. That'll also be big picture. So I've taken the other sections that we talk about in the second part and do a too long didn't read summary. So we'll have an abbreviated presentation, and then we'll have the second part, which is more details. And that's for those of you who are clinicians or who want more specifics. Legal and conflicts. To my knowledge, I don't have any financial or other conflicts of interest that would influence this presentation. I don't have any affiliate links connected with this or my website at this point, and the information provided is not medical advice. Regarding who I am and what my experience has been, in 2011, I received a Bachelor of Arts in Psychotherapy, Mindfulness, and Creative Expression from the University of Redlands in California. And I know some of you, by the way, are up in Canada. So I have some information here. There's some stats that are also Canada specific, but I just wanted to say that. So if you have any questions about American education systems or diagnostic systems, let me know. In 2015, I received a Master's of Arts in Mental Health Counseling and Behavioral Medicine from Boston University School of Medicine. That, of course, is in Boston, Massachusetts. And as part of that, I did a practicum in emergency services. That was a mobile unit where we were sent out into the community to go talk with folks who were receiving or who were in the midst of various forms of crises. And that was during one of the summers. As part of that graduate school, I also did a year-long residential addiction and substance use treatment internship at the VA Veterans Affairs Medical Center in Boston. That was mostly alcohol dependence, but also some cocaine, some opiates with veterans, mostly men. From 2015 to 2017, I was a counselor in a methadone clinic in Boston. So that was opiate dependence, and many of those individuals also had cocaine use or alcohol use or weed use. And I don't think there was a single person who didn't have a substance use, or not substance use, a mental health condition as well. A lot of anxiety, a lot of depression, a lot of trauma. And then from 2018 to current, I have operated a private practice out of Seattle. Through that, I started seeing substance use as well as mental health conditions, mood disorders, anxiety, depression, PTSD, bipolar. And then as I did, kind of uncovered my own neurodivergent traits and experiences, it turned out that many of my own clients had those. So I shifted to a focus with adults who are either undiagnosed or high masking neurodivergent. So at this point, I'm licensed in both Washington and in Vermont. My own personal experiences, I have both ADHD and autism, which tends to be abbreviated as or Audi, what's the phrase? It's slipping my tongue right now. ADHD, there we go, AUDHD, as well as nonverbal learning disability. So those were all identified as an adult after living with mental health conditions for many years and after completing both high school, college, and graduate school. So I can speak to both the personal and the professional journey I've had, as well as some of my clients. Big picture wise, so the big picture is that in both Canada and in the US, to my knowledge, it's a very siloed, fragmented healthcare system. In Canada, yours is a little bit more cohesive than ours, but it's still a fragmented system where mental health, physical health, substance use, and what we call developmental disorders, which is autism, ADHD, we'll get into those later, they're treated as entirely separate specialties. So you have someone who's a MD doctor who received almost no training, for instance, on developmental disorders, or you have someone who's a licensed mental health counselor who received very little education on substance use or on PTSD. That's changing, which is wonderful, but it means that depending on who you're talking to as a doctor, as a provider, there is no guarantee of what kind of education or experience your medical provider has received. So this means that it's, as an individual seeking healthcare, it's very expensive, it's very difficult to find relief, to find even providers who are cross-trained in 2, 3, or 4 of these specialties. So this is the context as to why my past slide, or why my education and experience has been so broad, because as I've worked in the field, as I've lived my life, I've gone and sought cross-training. And that's also why I do this work and why I like to talk to other providers to try and provide some framework and some context. For those of you who are providers, learning objectives: define neurodiversity and identify 2 to 3 types. Identify 2 to 3 mental health conditions that frequently co-occur with ADHD and ASD. And then identify 2 to 3 DSM criteria limitations, and why just reading these criteria. And this is for those of you who are not clinicians as well. I'm frequently asked the question of, why can't I just read online about these? Why can't I just read the criteria and learn everything I need to learn? And that's not the case. So this is my TLDR, presentation summary and takeaways. As we've talked about, feel free to type in questions that you might have, comments that you might have. Some of you I know have ADHD, so this is also, the chat is a way that you all can communicate with each other as well and stay engaged. Neurodivergence. So neurodiversity is diversity, and there are infinite variations of it. It's a biological fact. It's not an approach, a belief, a position. There is a social justice movement called the Neurodiversity movement. And by the way, these slides are more text heavy because some of you have said that you like to read. So the Neurodiversity movement is a social justice movement that we'll go into in a bit. And there is a specific approach called the neurodiversity paradigm. But especially in this day and age, neurodiversity movement, neurodiversity paradigm, those have all gotten mixed together in people's language. But neurodiversity, as in the spectrum of diversity of human minds, is not a philosophical approach. It's a biological approach or a biological fact. A neurodivergent individual is somebody whose mind operates in a way outside of what their society has classified as normal. And that normal phrase is one that is loaded, but there are part of what we'll talk about maybe in the second section is where some of those thresholds are for what is normal and why this conceptualization of normal may serve a purpose. But someone who's neurotypical means that the way your mind works functions or falls within what is traditionally what your society says is normal. Neurodivergence isn't positive, it's not negative, it's not neutral, or it's not desirable, it's not undesirable. It's a neutral thing. It depends on its nature, its impact, how the individual feels about it. Some forms of neurodivergence are intrinsic, things like autism, ADHD, they're part of how someone's brain has developed, how they've evolved. They're not necessarily experience related, whereas there are forms of neurodivergence, and this is something that doesn't get talked about as much, that are a result of experience. So this can be meditation practice. People who have had many years of meditation practice do fall into the umbrella of neurodiversity and neurodivergence. Folks who have had a lot of psychedelic experience, whether it's in a spiritual, religious, recreational pursuit, that does change the way your mind is wired. So that is also a form of neurodivergence. So are traumatic brain injuries and concussions. So I run into this with folks who have played sports and have had concussions as a kid or as you age. So that is also a form of neurodivergence. Neurodivergence and the medical model. Diagnostic and Statistical Manual of Mental Disorders is the DSM. It is the handbook that is published by the APA, the American Psychiatric Association. There is also an international ICD-10 at this point, which is the International Classification it's in a different one of the slides. But the DSM is what we use in the Western world frequently, or at least in the US. It's currently on the 5th version, which came out over 10 years ago in 2015. It's categorized, it's used to diagnose, it's used to allocate resources for research, it's used to provide accommodations. It is a highly flawed, massive book, which I'm looking for right now, that has its uses, but also has many biases. So part of what this 2-hour presentation is about is also where some of those flaws are, because these criteria is where most of the research you read on the web about these disorders are going to come from. So this is also, all of the disorders in here are through the lens of what is neurotypical, which means that if you're neurodivergent, then all the mental health criteria like depression, anxiety, PTSD is not through that lens. Which is why knowing what neurodivergence is such a big, important piece, because it skews how everything else is expressed. It also expresses a binary, as in you do or don't have these conditions. Autism's a little bit different in that there is more of a spectrum, but all of these conditions exist on a spectrum. And there is something called subclinical, which we'll talk about, where you have traits of. And all of these conditions are also, to be diagnosed, you have to have significant distress, and your symptoms have to cause impairment in your life over a particular time frame. So we'll talk about this more in the future. But according to the DSM and the ICD, also very similar, neurodevelopmental disorders include attention deficit hyperactivity disorder, which is ADHD, autism spectrum disorder, which is ASD, learning disorders, intellectual developmental disorders, communication disorders, and movement and motor disorders. So intellectual developmental disorders, communication disorders, movement and motor disorders, we won't be talking about. Learning disorders are specific to certain styles of learning or certain types of learning. So mine, NVLD, for instance, means my visual and my spatial skills are significantly worse than my verbal. ADHD and ASD we'll talk more about. But as a whole, neurodevelopmental disorders are brain-based conditions that affect how the brain grows and how it works. So they typically begin when you're a kid, somewhere between 2 and 13. So you'll start to see signs of them, and they do continue throughout your life. Your brain does develop, so it doesn't mean your brain is fixed, but the changing of how your brain, what am I trying to say? But ADHD, for instance, or autism, the way it manifests will change throughout your life, but there will be signs of it throughout most periods of your life. That can be a very tricky thing to explain to kids or to adults. This line between having a brain that is different, but also one that isn't necessarily broken, but that can be perceived as broken when it comes in contact with environments or societies that have certain expectations of what should and shouldn't be happening. So mental health wise, summary is that neurodivergence is a neutral brain variation. Challenges frequently arise from environmental demands and mismatches between the environment or expectations. Mental health conditions include substance use and behavioral issues. And what I've seen in my practice, as well as in my life, is that substance use, and I know several of you are substance use clinicians. So there's some slides further on about this. But substance use is frequently used not just as a way to cope with trauma. And those of you who are in the substance use profession know that trauma, PTSD frequently comes hand in hand with substance use. But neurodivergence, there's a difference in how you process sensory information, so touch, sound, taste, and how you process information in general. So frequently neurodivergent kids, adults will be using substances to help them manage overwhelm with sensory environments, overwhelm with information, social anxiety because they're in settings that they don't understand, or where they are just feeling completely disconnected from what's happening or out of sync with what's happening. They'll be using substances to manage all sorts of things, where if it's not a substance use that they're using to try and adapt to neurodivergence, it's a behavioral thing they're using to try and adapt. So sometimes that's video games, to help slow their minds down, as weird as that sounds, or it's gambling, or it's shopping, or it's TV. But there is almost always some sort of behavioral thing that a neurodivergent individual is doing at a problematic level somewhere in their life. Legal social difficulties often do also occur, and we'll talk about stats in a minute, from a mismatch, and that's something we'll also talk about. So a goal in working with the neurodivergent folks as a professional or as a personal person in your life is to shift from fixing people and focusing on what's broken to shifting to creating supportive environments. Because with proper supports and accommodations, and this word accommodation really just means flexibility. We've created this loaded word accommodation, but really it just means flexibility. So with proper supports and flexibility, many comorbid conditions may not actually even develop. So I have met neurodivergent folks who don't have mental health conditions or who have developed structure in their life so that they don't have substance use or legal issues. But it takes actual work and it takes education. Stats are tricky. Stats are really tricky. Take these numbers with a grain of salt. But some of the strengths that folks who are neurodivergent have include the bolded words here. So innovation and creativity, pattern recognition, hyperfocus, entrepreneurship, specialized knowledge, resilience, adaptation, diverse thinking. And there are significant benefits that these skills have for families, for societies, for the individuals. And I do have citation slides. I'll send everybody a list of the resources, the books, the citations, etc., that I used for this, so you can have access to those. But as you see here, we have numbers like 30 to 40% stronger, twice, specialized knowledge. Autistic individuals achieve expert level understanding in special interest areas, twice the rate of neurotypical peers. Autistic and ADHD individuals show 30 to 45% stronger pattern detection, higher rates of innovation. And some of these slides I can send you, like this one, because it condenses research. I can send you some of these slides. But as you see, there is high likelihood of significant benefit of neurodivergent folks in work, in home, in school. That being said, welcome to the not fun picture. About 50 to 70% of people with one neurodevelopmental variation have at least another one. About 70 to 80% of neurodivergent adults develop mental health conditions. It's estimated that about 20 to 30% of adults who are in substance use programs are suspected to have ADHD. I would say it's higher. About 5 to 10 are suspected to be autistic. Higher, but less high than ADHD, and we can talk about why. In adolescent populations, 30 to 50% are expected to be neurodivergent. So some pretty strong importance of neurodivergent focused substance use treatment. Neurodivergent individuals are 2 to 7 times more likely to be victims than perpetrators of crime. At the same time, there's also some information and some stats around high rates of neurodivergence in domestic violence perpetrators. So that's a whole nother can of worms. Because of the different style of communication and the different way that executive functioning, which we'll talk about, is expressed, there is a high likelihood of negative interactions with police when police are involved. So if you look at police violence, there is unfortunately a high correlation of neurodivergent folks who are involved in this as well. Incarcerated adults, 25 to 45% are suspected to have ADHD. And that's compared to ADHD being about 4 to 5% prevalence in the general population. That's probably low for reasons we'll talk about. But about 10 to 15% of individuals in the criminal justice system may have unrecognized autism. So here you can see that ADHD alone is highly overlapping with substance use as well as with incarceration because of the impulsivity factor. That's my guess, or at least correlation, causation. But if you're working with anyone, if you're a mental health counselor, if you're a substance use counselor, if you're working with anyone who's involved with the justice system, you are highly, highly, highly likely to have at least 50% of your caseload probably have ADHD, and then even higher if you throw in the other developmental disorders, and that changes the picture. Divorce rates for couples, this is the one that just breaks my heart. Divorce rates for couples where one partner is neurodivergent is about 60 to 80% when supports are not in place. But when you have someone who's neurodivergent and you give them a diagnosis and you give them supports, the rates of marriage satisfaction go up significantly by about 70% based on research. So here's another example of these disorders, if we want to call them that, or these brain variations, really, really, really impact communication and relationships and mental health, and it causes havoc in relationships. And if you give people information and help them to problem solve what kind of accommodations, what kind of flexibility is needed, things get better. And that's something I talk about with a lot of clients. So I'm happy to talk more about that in question and answer style. But frequently, my first couple sessions with people is mostly information, and then their depression rates go down, which is its own thing. And then sometimes we'll bring in family members or spouses for purely just information sessions and then problem solving sessions. And that is something that a lot of therapists don't do. And we can talk about that later, those of you who are therapists, how to bring this information together. High school dropout rates, 2 to 3 times higher for unidentified neurodivergent students. College completion rates, 30 to 45% lower for neurodivergent adults without accommodations, or we can replace that with flexibility. If you put accommodations in place, the graduation rates are about equal, and the success rates are about equal to people who aren't neurodivergent. Not a fun picture, which is also why I say neurodivergence is a difference in brain wiring that when it comes in contact with the surrounding structures of home, of work, of society, that's where you get these stats. TLDR, ADHD. So with ADHD and autism, the way I'm going to do this is I'm going to give you a summary, and then I'm going to give you a different perspective of how someone who's a specialist in the field has taken research, reframed it into a approach other than the DSM that can be used. And these are the last few slides that we have before a question and answer period. But I can also, if people want me to, talk about how I use these frameworks in my own clinical work. So ADHD. DSM, going back to this guy. There are technically 18 symptoms. There are technically 3 subtypes. ADHD inattentive, ADHD hyperactive, ADHD impulsive. If you look up ADHD online, this is what you will see. I have used those criteria before I knew any better with clients and told them I didn't think they had ADHD. A lot of clinicians have, and we have done harm because of that. These criteria are outdated. They're very narrow. They were developed between 1940 and 2013 to describe 6 to 12-year-old white upper middle class male boys with a very specific, narrow description. And you can have someone who's white upper middle class male between the ages of 6 to 12 who does not fit these criteria, who still has ADHD. So you can even take that narrow demographic and it can still be inaccurate. That being said, you can use, this is something I'll talk about too, you can use other criteria, come up with an idea that it's ADHD, be right, and then look at the DSM criteria and see it in the criteria, which is confusing, I know. So if people want me to talk about that, I am happy to talk about that because that is what I do. But to go from the criteria to applying the criteria to your client or to your family member, you can miss it. But if you go backwards, you can see it. And that's frustrating. The criteria for 17-year-olds plus, which is their adult criteria, was extrapolated from studies of kids. So there actually is no adult criteria, which is insane, or wrong word. It's just ridiculous. There is a focus on general symptom management and on behavioral interventions. The focus is on correcting problems. There is a growing body of research from specialists, as well as from people with a lived experience, from coaches, as well as many other people, impacting how ADHD is perceived, which is good. Unfortunately, it often falls to the individuals with neurodevelopmental disorders to educate our providers. And that's not fair, but we do so much educating, and I hope that changes. Some of the things that are missing: executive functioning deficits that we'll talk about and emotional dysregulation are nowhere in the criteria, but they are all over the presentation. So we'll talk about that one. Masking, we'll talk about masking in regards to any kind of neurodevelopmental disorder, but what it means is that we don't seem, all the things that we do to seem neurotypical. There are some alternative frameworks we'll talk about, one of them in about a minute. So we'll jump to this in the future, but there's a guy named Dr. William Dodson who's a practitioner, and he was one of the first people, I think, who he created an article that then blew up the internet. I don't even remember when it was, but he said, what does everyone with ADHD have in common that people with ADHD don't experience? Which is a good question. So he was one of the first people who started talking about interest-based attention. Neurotypical people pay attention, typically, generally, these are generalizations. Their focus, their attention, their motivation is based on what is important, what is priority, what is time. And if you take someone who has ADHD, our motivation is not on what other people say is important. It's not on what people say priority is, and it's not on what time. Instead, what you see is that ADHD people don't have an inattention, we have attention that is inconsistent, and it's only activated under certain conditions. Things that are interesting to us is the main one. I am interested in people, so I can tie my interest to my teachers. If I like my teacher, I can care nothing about the subject, but if I'm interested in the teacher, I will pay attention to the subject. That's an example of interest-based attention. Competition. Someone can be highly competitive, and that hooks their attention. Also, if you tell someone they can't do something, for some people with ADHD, and that's where you get some oppositional defiance stuff, don't tell me I can't do this. Don't tell me to do this. That can be another source of motivation. Novelty. Is this new? Is this shiny? Is this exciting? People will pick fights with partners to create motivation. People will, not be able to stick to boring routines. That is part of an ADHD system. Urgency. This is the one you end up with. The kid who doesn't do anything until the night before. So, not paying attention to what teachers say is important, not paying attention to what happens in 3 months, but instead paying attention to what is interesting to me. What am I incentivized by my own value system to do? What is novel? What is urgent? That someone will pay attention to, typically. So that's one of my screening criteria for people. Emotional hyperarousal, more intense emotional reactions. So there's a lot of shame, there's a lot of low self-esteem with people who have ADHD and other neurodevelopmental conditions. So we need people who really believe that we're good, that we're worthwhile. Rejection sensitive dysphoria. Not everyone who has ADHD has what's called RSD, but you see it enough that it's important to talk about, and it's debilitating. So RSD is an intense emotional reaction. Sometimes it's really easy to see. Sometimes it's really internal, and it's in reaction to perceived criticism. So I've had clients report suicidal ideation, for instance, from perceived rejection. I've had people relapse on alcohol when they feel like they've failed. It's an extreme emotional response. It also can be lashing out at a partner. It can be saying something really sharp and unintentional. It can be completely collapsing internally and being able to get out of bed. It can be rumination for days or weeks or months about a single thing somebody has said to you. It's debilitating, and it cannot be treated with it shows no therapy. Doesn't do anything for it. We can talk about this one. This one's fun. It's intense, it's immediate. There is some relief, but it's all over first person accounts of like about two thirds of people with ADHD will report this. Treating ADHD, stimulant medication is really, really effective. Things called alpha agonists, which are actually blood pressure meds, things like guanfacine and clonidine, help a percentage of people handle the rejection sensitivity. Therapy is great for some of these things. Coaching, executive functioning coaching, and ADHD coaches are great for some of these things. But in general, treating ADHD is a combination of medications to address ADHD symptoms, plus mental health meds frequently, plus coaching, plus education, plus therapy. Some combination of that. And you can have therapists who do executive functioning coaching too. So last bit we're going to talk about is autism. and then we're going to open the floor up for some questions because I know I'm throwing a lot of stuff at you and it's only been like 45 minutes. So, autism. Autism, conceptualized as deficits in social communication and restricted repetitive behaviors. What does that mean? Just like with everything in here, clinical language is a little bit like legal language in that words have specific meanings. And it also means if you're handed a report as a parent or as a regular person from a medical provider, it's pretty likely you're not going to be able to understand it, which is an issue. So there are a lot of people, myself included, who have had parents or have been handed reports with terms that make no sense and then don't get understanding or treatment because the language makes no sense and people don't take the time to explain what medical language or language in reports mean. So we can talk about this in these Q&As, but there's really a social justice issue here. So autism, typically the focus is on early intervention as kids and teaching neurotypical social skills and communication. Autism, like ADHD, over the last 100 years has had really big swings in what's considered autism, what is considered a symptom, which is why you end up with such increasing prevalence rates. So as you can see on these slides, like 1 in 2,000 people in 1980 were considered to be autistic. In 1990, it was 1 in 50. In the 2000s, it was 1 in 110. So there is an increasing aware of what falls under these spectrum, ADHD spectrum, autism spectrum. And so in 2013, when the most recent DSM came out, Asperger's was removed. Asperger's was a term for high functioning autism that, believe it or not, was developed. There's a great book, you guys I'll send this, but there's a book called Unmasking Autism. You guys can't see this, yeah, I don't know, well, I'll send it to you. Unmasking Autism by a man named Devin Price, who we'll talk about in a minute. But he and others have looked into the research, and Asperger's, the criteria was developed to help high functioning autistic kids appear more valuable so that, believe it or not, Nazi Germany wouldn't send them to concentration camps. That is literally where this comes from. Hans Asperger created this group so that they wouldn't be sent to concentration camps because they were perceived then to be more valuable. So in 2013, Asperger's was removed as a diagnosis and it became autism spectrum disorder, level 1, 2, and 3, based on severity level and supported and support needs. So Asperger's became level 1. Criteria for ADHD, for autism, for a lot of mental health conditions is based on what is observable by people outside of the individual who's experiencing it. Similar story, observation of white, male, upper class children, adult criteria extrapolated from child studies. And in the last 5 years especially, there's been a huge amount of awareness to what is needed to change in the criteria. We need adult-specific criteria. We need more information from people who live these conditions. There's a huge amount of burnout that happens from masking that then looks like depression or looks like social exhaustion. There's a huge cost to sensory differences in autism. And that's nowhere in the criteria, really. It's a little bit in there, but not enough. Masking, as I said, is unconscious or conscious suppression of communication differences, sensory differences, all sorts of differences. And it's a survival strategy. It's a trauma response. And it's done to try and survive and to try and not be different and to try and not be excluded. So in many ways, drinking if you're socially anxious is a form of masking for those of you who work in that field or who experience that. And there's a lot of subclinical substance use disorders, for instance, that can be attributed to masking of brain-based differences. So, Devin Price, this is a great book. I'll send it to you guys, but he has some criteria for autism. He is autistic. They are autistic, I'm sorry. They are autistic. And wow, my brain. They are creating their own list, or they have created their own list that I've put here to try and give space. So sensory processing differences, heightened sensitivity to sensory input, lights, sounds, touch. So tags, you know, the feel of tags in your clothes or the feeling of a bra strap, skin that's sensitive against jeans, that kind of thing. Sensory seeking behavior sometimes. So like there's in the book, there's a story of someone who loves roller coasters because the intensity of the sensations is calming. So people, I have some autistic clients who love to ride motorcycles and go to rock concerts. And that doesn't mean they're not autistic. So feeling overwhelmed in busy or chaotic environments is another sensory processing difference. Difficulty filtering background information, sensory processing difference. Social information processing, difficulty intuitively understanding written rules. Finding social interactions mentally taxing. There are a lot of people who identify as highly sensitive people, HSPs, who actually fall underneath the like subclinical or actually autistic umbrella. A lot of people who identify as introverts. If you hear any of these terms, if you're a clinician, start asking questions, because it probably is a processing thing, even if it's not autism. Trouble understanding implied meaning. So intensity and hyperfocus, deep passionate interests, ability to focus intensely on subjects, difficulty transitioning between activities, strong need to understand systems and patterns. So this is the one that people will sometimes say, oh, boy is interested in trains, must be autistic. I am obsessed with psychology, still a special interest. It just is socially acceptable. Girls who are interested in horses, acceptable. People who are obsessed with specific boy bands, socially acceptable. So look at the intensity level and not necessarily what someone is obsessed with. Also look at systems and patterns. So a lot of specialists in certain professions might have some traits of autism. This is my last slide, I think. Yeah, my last slide before we talk about where you guys want to ask questions. Need for predictability. Distress when routines are disrupted. Comfort in repetition. Anxiety around unexpected changes. So this one I'm going to highlight because not everyone has a full-on meltdown when plans change. Also, when you have someone who's autistic and ADHD, which happens more than you think you do, it gets really confusing. So sometimes you want chaos and sometimes you want predictability. But anxiety around unexpected changes. That one I'm going to highlight. Divergent thinking, so approaching problems in unusual or creative ways. Strong sense of justice and questioning arbitrary rules. Wanting definitions to be clarified. All of these are potential autism yellow flags. And my goal here is not to say these are, these aren't, but to give you a bunch of yellow flags that will make you ask more questions when you're interacting with yourself or with other people. Identity and self-perception. Feeling fundamentally different is a big one for anyone who's neurodivergent. History of being a chameleon, picking up personalities, picking up hobbies, being really interested in them for a while, dropping them, exhaustion from social situations, even when you're enjoying them. All of these are kind of yellow flags for neurodivergence. And then some people want to know what kind of neurodivergence, some people don't. And that's their choice. Not everyone has to know what kind. So the point here with all of this is that the brain is a really complicated, fascinating, amazing muscle brain thing. I don't know what we want to call it. And variations are normal in many ways. But variations when we don't know that there are variations, and variations when we don't have flexibility in our systems, can cause things like substance use or mental health conditions or getting arrested or being laid off from jobs. And knowing where your variation is doesn't necessarily help, but it might help depending on if you're someone who needs that. So that's the end of part one. The way I want to do this is we can have questions, and feel free to ask information related or personal experience related or clinical experience related. Just please nothing about politics or religion.
Katie,
Yes.
just wondering, when you talked about doing a reverse assessment from the DSM by starting with a different type of criteria first, was that the type of thing that you were referring to when you explained the Devon Price's criteria? Is
Yeah.
that something you would use and then go back to the DSM and you'd see more of those traits? Yeah.
Exactly.
Thank you.
You're welcome.
And I'm wondering too if it Dr. Dodson criteria or his understanding and framework of ADHD that you use to work backwards as well.
Yes, I do.
Okay.
And I can speak more to that in a minute or so. But yes, both of those are ones where if you use those two to screen people and then you look at the criteria, you can see it.
I'm curious, Katie, about if you heard anything about how epigenetics plays with like ADHD symptoms. I know for me, like I think they showed up a lot more when I was an adolescent, and I don't know if it was just debuting, but I had a lot of stressors, like pretty extreme stressors going on at that time.
Yeah, so tell me a little bit more about what your question is.
Well, I know for myself, I've been diagnosed with ADHD. I probably have ADHD, but for instance, I was always like really good at like doing my homework on time and things like that in school as a kid until about 13, 14 when my parents divorced.
Mm.
But I also like started to get turned off from school because they were having us do a lot of rote memorization and things like that. So it's like, but but the symptoms became much worse, and there was a lot of stressors. So I wonder if there's like a predisposition, but then it kind of jacked up, my symptoms or kind of turned on the ADHD more than it might have been.
Yeah, it's Okay, so symptoms typically get worse around transitions,
Yeah.
which is where,
Hormonal and life transitions.
yes,
Yeah.
and it'll be like when kids leave home, when someone goes to college, when you disrupt the environment around somebody,
Mhm.
and then you throw in a bunch of other things.
Mhm.
So the
Yeah.
hormonal piece is a piece, and
Yeah.
transitions is a piece.
Yeah. Okay. Kind of like how bipolar can sometimes debut when folks go to college.
Mm-hmm.
So I did type my question, but I was asking about your experience, both personally and professionally, in the process of shame reduction that's so tied to this.
Mm-hmm. Shame as connected to this is sort of complicated in that there's shame around terms and then there's shame around not having a term. As strange as that is. Like there's a reduction in shame I've seen when people have an acknowledgement that there is something fundamentally different about them, whether they want or need to know what it is particular to the individual. But to have someone be like, yes, there is something fundamentally different about you, and it makes complete sense that these behaviors you've been involved in, or this, history of divorces, or this history of mental health, of course that's happening. Like that's part of this picture of you trying to live a life with difference that you didn't know about and that there hasn't been flexibility around. So there's a lot of reduction of shame that I've seen come from people getting information. And then there's another layer of, I don't think it's shame as much as it's weight. There's like this weight that comes down on people of like, oh shit. Sorry, but like, oh shoot, like, what do I do with this? Or, gosh, these statistics are overwhelming. Um, so I think everyone's shame is a little bit different, but I've seen depression that's not actually depression. It's depression secondary to shame, or depression secondary to trying a million different ways unsuccessfully to adapt to a brain difference. Um, so I think, where is the shame highlighted that you see around ADHD or neurodivergence?
Thank you. I think just speaking about it openly, and it's very explanatory, and I can look back all through my childhood and education, and like you, just getting hurdled through school and never having anybody notice, and then finally hearing something about it that's explanatory. You kind of go, oh, well, that makes total sense, and that alone reduces shame, I think, and having validation. So thank you. Yes, that did answer.
Yeah. There's a lot of there's a group of people that I fall into as well, of people who appear really successful and are really successful and made it through school, somehow, but made it through school, made it through life in many ways, and internalized a lot of the difficulties, or just had good strategies from other means, and then hit a wall. And there's a shame that happens there too. And that's a lot of my clients, where they hit like a big tech job. They hit their Microsoft job, or they hit COVID, or they hit having kids, or they hit being laid off for the first time. And there's a whole bunch of shame too around people who are successful or together, and then having areas where they're not together. So any other questions, comments?
More of a comment to just
Yeah.
really support what you just said. I work with many people where that's the situation. And, full disclosure, I experienced that myself too. You know, feeling like, okay, knowledge and understanding, I mean, that's power, right? Understanding past experiences before diagnosis, putting them in a new framework. Okay, yeah, that reduces shame. Learning some tools to accommodate and be flexible with symptoms that are presenting. Okay, getting somewhere. But then something happens, right? Different
Yeah.
expectations at work, or um, for women of a certain age, menopause symptoms just jack up the ADHD or autism experience. And then the shame comes in. Yeah. So what I've seen with high achieving individuals is they may have that initial diagnosis, go through that whole phase of reinterpreting, reframing past experiences. Okay, now I understand what, this origin is of some of the challenges I'm having. They come to me and go, okay, now fix me. That the pathological viewpoint or perspective is really used there. So
Yeah.
it's interesting because that shame is still present. It's like, okay, now I see what's going on. Now, you know, how do I be more neurotypical?
Yeah. And I see it, I see the shame show up a lot around the consequences of the neurodivergence. So it's the one I see a lot is people in room cleaning or like dishes or um, clutter or like the things that are embarrassing. But one of the things I've said to clients all the time is, or I've said to some clinicians, but frequently people's shame is actually around a neurodivergence. It really is. Like, if I can get people to tell me what they're ashamed of, it almost always is. If you dig down, it's rooted in like a brain difference of processing space differently or being impulsive or like you can start chipping away at it and it's and that's my autism that comes in. I'm like, what is this? What is the pattern? What is the pattern? What is the pattern? um, but it's shame by itself is such a different complex subject.
Yeah.
Yeah.
I remember thinking like, am I ever going to be an adult at home? Like, am I ever going to be able to be a
Mm-hmm.
grown up, like have my kitchen clean and, kind of have things in good order? You wouldn't, you wouldn't have known that about me in the outside world.
Mm-hmm.
It was like it was a secret shame for me for a long time.
We had two more questions. Did you see the, can you
I
see the,
just saw them. Yeah.
who's
One,
it?
did you want me to read it or did you want to elaborate?
Um, it's just an observation,
Yeah.
it seems so many people that I deal with fall into this category,
Yeah.
one of these categories.
Yeah.
And what is the difficulty, if there is one, with seeing it in everyone
Mm-hmm.
and thinking it's something that needs to be addressed?
Yeah, I think that's the conversation of doesn't everybody have ADHD? Like
Yeah,
that's
seriously.
conversation. And this is part of the spectrum conversation. So going back to the neurodiversity is the spectrum of human brains. We're all part of this diversity. And with the diagnoses, with the categories, you need significant distress, you need significant impairment, you need over a certain time. So this is one of those things where diagnosing this stuff, you can look at any of the things we've talked about and traits, like executive functioning skills. Those are, if you think about an executive assistant, all the things that an executive assistant does, from like time management to planning to prioritization to task initiation to like the things we call adulting, that term that we use, the adulting skills, that's all executive functioning skills. Every single person alive has executive functioning skills they're better at and ones they're worse at. But how bad are they? You know, like how bad are they? If you've got someone who cannot keep their house clean to the point where they're hoarding, there is a spectrum there, you know? And so if we think about these pervasive developmental disorders, so you can have someone who has traits of introversion and like, okay, you know, I have traits of introversion. I've got some sensory difficulties. I, you know, get overwhelmed sometimes. But have you ever almost gotten fired for it? Was it true when you were 6 and it was true when you were 60? Have you ever developed a drinking problem because of it? Have you lost friends because of it? Have you, like, the level of impairment? And this is the thing too, where you can, one of the things that Dr. Price talks about in his book is you can identify with being part of the community without having the disorder. So like if you identify with the traits of, there's another question here about assessment. You know, if you identify with a bunch of the criteria that are listed, you can say you're self-identified as part of this neurodivergent community, and that's okay. You don't have to have a doctor tell you you have autism to identify with autism traits or the autism kind of experience. And so really, in some sense, if you identify with some of these things, go read about it. And, or, you know, if you have family members or colleagues who you think might be on these spectrums, start playing around with how you communicate or how you structure your interactions or time to be neurodiversity informed. And that's kind of where I lean in my recommendations. I'm like, learn about this stuff, and you don't necessarily need to go diagnose somebody with it, like your co-teacher, but using these pieces of information, start playing around with your interactions with them and your structures and see what happens. It might make the experience better. And it also just makes it more neurodiversity informed anyway. So,
Okay.
yeah, so this is the beginning of a conversation and it's really complicated. But it's, you know, I'm somebody who words matter to me. So that's why my word obsession and my like autism pattern recognition means I've gone down my own rabbit holes and figuring out exactly where my specific areas of strength and challenge are. And I need that. I've got other clients who like looked at the list of Price's criteria, not criteria, like themes, and said, okay, I think I'm autistic, and didn't need to do anything else. That's all they did. And I'm like, great. But otherwise, sometimes people do need to know, like, I'm X percentile on sensory processing. For those of you who are here for the next 40 minutes, I'll flip back to the slide that had kind of possible places we can go. And I would like to know where you want me to go. But like I can go through slides in the order that I created them, or I can focus in on specific places based on what you all want me to do. Checking in, was there anything that you wanted to elaborate on your typed point?
I think you kind of already spoke to it, but yeah, it's kind of a personal question really because I've always really identified with all of the autistic traits, but I always get really stuck on the like the tendency to use direct communication because I'm like, well, I sometimes do that, but often I'm actually, very indirect. And so then I'll be like, oh, so that means I can't identify with any of the other ones. And so I maybe like overthink it. And so I guess, yeah, part of it is just like, that question of like, okay, if you identify with so many of them, but there's one that sticks out that you don't identify with, like, could that be the masking, or is there something else going on there that's like, because I generally in the past would be like, oh, I must just be HSP then, or and just or an introverted. So that's, I guess, yeah, just my curiosity. And especially even working with clients as well, I know that they sometimes have a tendency to be like, oh, this one thing doesn't like fit, so do we just like ignore all of it?
Good question. Question: have you ever argued with somebody about words?
I think, yeah.
I mean, this isn't a definitive, but the number of arguments, this is a subtype of autism probably, but like the number of arguments I've gotten into over definitions of words, of like, you didn't say that, you said this. Or you used this word and I thought you meant that, but did you mean this? Like, that's literal. And so nonverbal learning disability is not autism, but it's funny because in this Unmasking Autism book, he talks about nonverbal learning disability as part of the autism spectrum, and it's not. It's a different thing, which is what we're talking about here in this like word specific obsession of mine. But it's so word obsession can be slightly different than the autism piece, but at the same time, literalness can come under several umbrellas, one of them being words. And I think it may be also that if you identify with a lot of these points, start exploring, see. And it may be that your literalness comes up in some areas and not others. But I don't think everybody who is on the autism spectrum is necessarily literal.
Well, I actually have gotten the feedback from people many times, you are way too literal. So like,
There you go.
I do feel like that does show up, but
yeah, in one of my assessments, I was asked if I was literal, and I was like, I don't think I'm that literal. And my husband was like, what do you mean you're not literal? So if you're told by other people that you're literal, then that's a data point.
I'm most interested in, like, as a clinician, what you recommend as far as working with folks. I mean, the more I know about this and I know about myself, the more I see it in my clients, and and talking about it with them and doing a lot of shame busting, as I call it, with them is a big piece of it. So I'm curious about your perspective about that.
Yeah. Yeah. So it sounds like audio ADHD things from reading here. Audio ADHD things, neurodivergence and substance use for supporting clients who may or may not be diagnosed. And what you're going to see, whether you're a person moving around in the world or you're a clinician, is you're going to see behaviors on top of neurodivergence. That's what you're going to see. So when you're looking at a client or you're looking at a family member, know that there's an iceberg. And to see the things underneath the water, it's about creating hypotheses and then testing them. So you can assume everybody you meet has this is me, that I've got no research for this. You can assume everybody you meet has some way their brain processes that is different than you would expect. You can assume that. You can also assume everybody you meet has a trauma history. COVID by itself makes a trauma history. So you can assume everybody has a trauma history. You can assume everybody is processing or interpreting information and sensory things different than you would necessarily expect. You can assume most people have subclinical, meaning like not necessarily diagnosed, but you can assume everybody has anxiety and depression that is not diagnosable. So everybody in the world as like a human being has a period, because depression is 2 weeks. If you meet certain symptoms for 2 weeks and you have a level of intensity that's high and it's getting in the way of your life, that is depression. So you can assume everybody, not that everybody has had depression or anxiety in their life, but that if you sit down with them, if you talk to them, there will be elements that just haven't impacted their life enough for it to be significant, or isn't significant, or they've had it. So I think there is neurodivergence everywhere. There's also, for those of you in the substance use world or in the mental health world, you can also assume everybody you meet has at least one behavior that they are doing or have done in the past to adapt to the environment that has not helped them. So those are my starting assumptions. And then for clients, I start digging. I'm like, okay, where is your trauma history? How severe is it? And then I start thinking, how do they connect together? I'm like, okay, where is the behavior that is a problem? Is it drinking? Is it social media scrolling? Is it gambling? Is it shopping? Is it audiobooks? People have behaviors in response to their environment and to their brain chemistry. That's really reductionist, I know, but it's like, okay, where are people's behaviors? Where are they rooted? Where are the problems? And then figuring out, is this, getting one of the things I don't even know if this is answering anybody's questions, but I know, right? Also with all of this, diagnostic 101, or for me at least, client 101 is they need to go see a medical provider and rule out medical issues. So it's like, do you have a thyroid condition? Go get blood work. When was the last time you saw primary care? When was the last time you got blood work? How is sleep, food, exercise? Like undiagnosed sleep apnea looks exactly like ADHD. So, and go encourage people to go to doctors, rule out things. So most of the time you can also assume someone has a medical condition. So just start with your clients, start creating these hypotheses, and then figure out how much information you need or if they want you to know. So you can also ask people from a neurodivergent perspective. You can ask your clients. I always ask them, how do you learn best? I say, I can give you, my intakes. For my intake with somebody, I have a fill in the blank intake form of, when was the last time you saw primary care? What are you here to see me for? What medications are you on? I also have anxiety, depression, ADHD, alcohol, and PTSD criteria, standardized forms I have them fill out, and I tell them, I'm giving you this not to give you a score, but because I'm cross-referencing the answers across all these different things. I'm cross-referencing across the questionnaires. I'm also cross-referencing what you tell me over Zoom versus over the phone when you can't see my face versus in a Likert scale or a Likert scale and in the fill in the blank. So asking people the same information across as many different communication styles as you can is also another good way to support people. I don't know if I answered anything, but it's... So this is also why I have a PowerPoint that's really detailed, because I go everywhere. So I can either do the PowerPoint or we can keep doing kind of question answer and see where the question answers go, because it is going to go nowhere organized. ADHD. So ADHD, autism. So for those of you who are clinicians, anxiety and depression are siblings. You have clients who have one who frequently have the other. ADHD and autism are very similar, where you have neurodivergence. And people, from what I've seen in my clinical world, people tip towards one or they tip towards the other. And over time, things unfold, but they tip towards one or they tip towards the other. And when you have traits, and this is the way I talk about it, I talk about traits of, like when you have traits of both, it can be very confusing for the individual, because you have like the inability to follow a schedule because your interest in ADHD case, if you're an interest-based person, you're crisis-based, you're interest-based, your priority, or your own priorities-based, that seems to completely clash with the autistic, I need structure. And so that is confusing. So I think exploring confusion with people when you have traits, whether it's ADHD and autism or ambivalence from an alcohol perspective, exploring with people how they can coexist with the conflict, as well as what they can learn from the conflict. Because they both can be true. So with someone who's like ADHD, what was the last unhappiness I had with schedule? So like with someone who's ADHD, they might say, I need to exercise. I want to exercise. I know this is important to me. I'm committed to exercising. I can't stick to a routine to save my life. That might be the thing that they present with. And the I need to do exercise might be how autism shows up for them, where they're like, this is my routine. I know I need to meditate. I know I need to do exercise. I know I need to eat right. And it's not because other people tell me, it's because I care about it, but I can't stick to the routine. And that might be part of how like the ADHD clash happens. And so then figuring out with them, for instance, okay, you need to exercise. That is something that we need to find a way to put into your week or your day with flexibility. So how do we find you 4 or 5 kinds of exercise that you're interested in, because you're not going to stick with one, but you can rotate them. And that might be part of how it is. Or, okay, we're going to create you a structure for your day, but, and this is the way I do it, I have blocks of time where, Brittany can tell you this, I will not stick to the plan of what I'm supposed to be doing. But if I have 3 or 4 things that I want to be doing, I can choose within this 2-hour block which of those things do I want to do. But I won't do the thing that I've blocked my calendar to do if there's one task I've put. So I think exploring the conflict helps a lot, and then creating flexible structures that are informed by executive functioning. So if you guys haven't gone down a what is executive functioning rabbit hole, I highly recommend that one. And then in your conversations with your clients, don't just ask them about their mood, don't just ask them about like what part is active, but say, all right, where are the executive functioning issues and how do we create some sort of plan to address the executive functioning issue other than get a planner. So that's my, I guess, main point is learn about executive functioning and start trying to weave that into your work with clients, because all of the developmental disorder stuff is partly executive dysfunction. People knowing, yeah. Book or resource on executive functioning. Do I have a blog post on that? I might. I've been writing blogs recently on my website. Really, the executive functioning stuff. Did I? I feel like I did. Didn't I write a blog post on executive
Yeah,
functioning?
I'll look for it. You can keep going.
Yeah. So, Marianne, by the way, can I disclose this, Marianne, what you do professionally? Or Anne Marie, can I disclose? So Anne Marie is a ADHD executive functioning coach. So Thomas E. Brown is who she recommends. Yeah, I mean, what's his name? Russell Barkley has a massive book on executive functioning. And I do have a slide on Russell Barkley. He's a researcher who has he's been doing research on ADHD for like 20 years. He's where a lot of the like ADHD executive functioning conversation that I've run into is, so any of his stuff. But
So there was two of your blocks that stood out, the dishwasher dilemma and then when life overwhelms. Was there one in particular?
right, so executive functioning. So I wrote a blog post about how everybody's arguments about the dishwasher are actually about executive functioning. That's like a 101, because this was one of those conversations where everyone was arguing with their partners about the dishwasher. So I started asking questions to figure out, and it turns out people were arguing about executive functioning deficits. And that then when I said to clients, I think your partner has an executive functioning challenge in this area based on what you're telling me, or I think this is where yours is. Like your strength is this, their deficit is this. They took that information to their client, not to their clients, to their person, and used the type of questions I'd been asking them or used the information. And it turns out it was an executive functioning issue that they were arguing about. And then they were able to problem solve how to support each other's executive functioning issues or strengths and have more compassion about it. So that's one.
And if anyone else, and if anyone doesn't have any other questions in regards
Substance use.
to that, exactly. I was going to go to the next one.
Substance use. So best practice for supporting clients with or without official diagnosis. I would say to kind of tie to this, one of the things about executive function, using an executive functioning lens, is that it's not actually pathology. Like everybody has one. Like you can take someone who's completely neurotypical, like run of the mill, everything's normal about them, they're completely even. They are going to have some executive functioning skills that are better than others. So you can use sort of a lens, and if you can help someone figure out where their strengths and challenges are, sometimes their alcohol use or their mood stuff or their problems in their relationships or et cetera, or their problems in work, it frequently does tie into executive functioning, because another two executive functioning skills, one of them is managing your emotions and another one is meta awareness, so like the ability to reflect on what you're doing. So both of those are executive functioning skills, depending on your definition. But so I think helping people identifying, at least for yourself, where their challenges are and where their strengths are. And another one is as far as neurodivergence. Knowing for yourself that in many ways, from what I've seen at least, folks are sometimes using substances to change their brain chemistry, which does then tend to be connected to neurodivergence. So there's another blog post I wrote because I was running into this all the time. Under and overstimulation. So this isn't anywhere on the slides. I didn't get to this, but folks who have ADHD, their brains, our brains, are understimulated. So that's where you have part of what stimulants do is stimulate your brain, or like the people who go to coffee shops to focus because they need the background noise, or people who are listening to TV shows or podcasts while they're doing something boring. That is to increase stimulation to get you to then do the task you don't want to do or can't do. So sometimes what people are doing when they're drinking or when they're using is they're either trying to give themselves more or less stimulation, which then is either connected to kind of baseline brain chemistry, or it's connected to processing their environment. So, if you have someone who's in Costco 24/7 and they have autism and they can't process things, they might take or do something to decrease the stimulation or to decrease their awareness of the stimulation. So I'd say, just like with executive functioning, thinking about how is the substance use, creating a theory in your mind, how is the substance use helping them either increase stimulation or decrease stimulation, both in their brain and in their processing of their environment. And I would bet, depending on your definition, because substance dependence does change your brain, I don't think it's considered a neurodivergence like psychedelics would be, because psychedelics have more of, it's kind of a different neurochemical interaction. But they are changing their brain. So it might be a form of neurodivergence, just like long-term trauma could also be. So you can consider, long-term, like complex PTSD, arguably is also another form of neurodivergence. Yeah, I don't know if that might send you off in more questions than answers, but okay. While you all are thinking, I'm going to take a look at this slide and see if there's anything that I didn't touch on. So neurodiversity paradigm, here we go. It's a specific perspective on neurodiversity founded on 3 core principles. Diversity is a natural and valuable form of human diversity. The concept of a single normal or healthy type of brain is a cultural fiction. And social dynamics around neurodiversity mirror those of other forms of human diversity. So this you've seen kind of woven throughout my presentation. And then the neurodiversity movement is the social justice movement connected to kind of neurodivergence and the paradigm. And it's not a single group or organization. But this article is one that I'll send you. I think we talked about neurodevelopmental disorders. So these 6, ADHD, autism, learning disorders, specific challenges with reading, writing, words, or math, intellectual developmental disorder, differences in thinking and adaptive skills, communication disorders, challenges with speech and language, movement and motor disorders, differences in coordination, or repetitive movements.
Maybe where does NVLD fit in with that?
Funny story. NVLD is not technically in the DSM. I know, right? So NVLD is nonverbal learning disability. It is an actual diagnosis that you can be given through neuropsych testing. And what they look at is the percentile differences between two sets of scores. So it's very, very specific. It's been diagnosed since the 80s. It's not in the DSM, but it has a pretty, it's very specific in how it's diagnosed. And it technically, the diagnosis I got for it was learning disorder not otherwise specified. That's like the code, the billing code you use, learning disorder not otherwise specified. But then there's an organization called nvld.org that has a lot of good information. And learning NVLD, sometimes people are diagnosed with it. Sometimes people with autism are closer to NVLD, but and this is where it comes down to the person who's testing you, the person who's diagnosing you, they matter a lot in terms of what their education is and what their background is, in terms of the diagnosis they give you. And it comes down to some people choose to identify with NVLD instead of autism, or vice versa, or both. But maybe I should just start recording things and posting them on YouTube about these topics. But I'll do something on NVLD, but it's technically a learning disorder. Does that answer your question? I think that answered. Anyway.
Yes, it did. Thank you.
You're welcome.
And I also shared a link to your resources page because you have a couple other resources for NVLD
Nice.
on that page. So I shared that with everybody.
Thank you. Oh, so ADHD, hyperactivity. In adults, it's typically, hyperactivity is mental, it's not physical. So for those of you who are clinicians, the folks whose brains are binging around and like can't settle down at night unless they exercise, especially, that's probably hyperactivity. It looks like anxiety sometimes. It looks like distractibility. But for adults, hyperactivity is most often physical or mental and not physical. Meltdowns and shutdowns, which I didn't have time to talk about even in the slides, in masked autism are frequently perceived as personality disorders by clinicians, like narcissism or borderline personality. So that's something I might write or talk about. But meltdowns and shutdowns, like mine especially, or people who I've seen as clients, shutdowns look like dissociation. So if someone has PTSD especially, they might actually be shutting down and not dissociated, which is when your brain the shutdown is when your brain is just overwhelmed, and it short circuits really. And a meltdown looks more like, well, actually, it's the like, I can't do this anymore, I don't know how to do this. It's the, I'm overwhelmed, I can't handle this, there's too much happening, I just need to go, I need to go, I need to go. Like that's more of a meltdown, and it's this like energy outburst that can be violent, it can be verbally violent, it can be snapping at somebody to push them away. Meltdowns can flip into shutdowns when someone has done something or said something because they're overwhelmed, and then they are feeling ashamed. So meltdowns will flip into shutdowns, and then it'll get diagnosed as a personality disorder. When it I mean, if it's autism, and that's also pervasive, which is why people will look at it sometimes and they'll say, this doesn't quite feel like PTSD. And it's been there since a teenager, so maybe it's like narcissism or personality or something. So I think pulling apart a lot of these diagnoses is a much bigger topic. But I just wanted to put meltdowns and shutdowns can happen in ADHD, but they are more likely to happen in autism, which is where with ADHD, if you have someone with ADHD who's having meltdowns and shutdowns, that might signal to you that it's more of an ADHD thing. And I think I also had I wrote 2 blog posts about meltdowns and shutdowns. I've only written like 6 blog posts. So if you go to my blog post page, there's only about 6 of them. And 2 of them are about meltdowns and shutdowns.
I'm wondering if you have any tip for best practices if a client experiences a shutdown in a session.
Mm-hmm. So with shutdowns, decreasing stimulation. So sometimes if someone's shut down, sometimes the things that you do, if you have a background in treating PTSD, when someone goes into hyper or hypoarousal, like hyperarousal is more of that anxiety, fight, flight, hypoarousal is the freeze place. So sometimes the skills or the tips that people use for hypoarousal, where I guess, no, with hypoarousal, you want to get them moving, but if someone's shut down, seeing if you can get them talking, but not overwhelming them. Seeing if you can get them moving, but not a bunch of movement. Giving them space so that they can come back to you, and holding that space, and letting them bring their systems back online, because it's overwhelming. Like people shut down when they're overwhelmed and when there's too much happening. I've seen it with clients frequently happen in arguments with partners, where they'll get overwhelmed and overstimulated and then they'll retreat. But it's very individual. So if they know they're doing it, you can ask them what would help them. And if they don't know they're doing it, seeing what brings them comfort helps. Seeing if they're willing to talk about something that they enjoy sometimes bring people back online. Letting people step away from a conflict if they need to. Just creating space, however that needs to happen, while remaining in contact.
Yeah, I guess that's really my question.
I don't know. It's a good conversation though, how to support people. And I don't think anyone really knows.
Yeah.
There isn't a good.
Because we're all individuals, right? And
Mhm.
context matters so much. Yeah.
Yeah.
But thank you.
So I think we had a slide about my social media. But yeah, these are the QR codes. You can always schedule consults with me. You can go to the website and we can talk about specific clients or situations. Thank you.